Hi, everybody. Hi. Happy Wednesday afternoon, everybody. Good to see you all. Welcome. I can see Jess and Ingrid. Everyone's a familiar face now. Hi. Hi, Megan. Now, we're just going to give everyone a minute to join. This is a very exciting presentation, and I will introduce our speaker in a minute. But while we're waiting, hi, Jenica. While we're waiting, if we could get everyone to introduce themselves in the chat, their role and where they're joining us from, that would be wonderful because this is always a very exciting part of the webinars where we get to see where everyone is. Who's going to, always a race to be first. Let's have a look, everyone. Hi all. Hi, Ingrid. Tanya. Hi, Tanya. Thank you for being here from Shepparton. I know most of the names now, which is really lovely. Jen from Wagga. Hi, Jen. Hi, Jenica. From Eastern Palliative Care in Melbourne. And Ingrid's from Albany. I thought I knew that, but I couldn't remember Ingrid. Jess. Hi, Jess from Monash in WA. We'll just give everyone a few more minutes. There's Kate. Hi, Kate. Hi, Nicola. Hi, Tanya. Hi, Lisa from Uniting Age. Well, hi, and that's in Melbourne, isn't it, Lisa? Jess Morgan from Barwon Health. Hi, Jess. Hi. Apologies if I pronounce your name incorrectly. And Androni, you can unmute yourself and correct me if you'd like. Oh, welcome from Perth. All right, I think 3 minutes is enough.
Thank you.
Oh, is Androni did I say that correctly, Androni? Wow, that was amazing. Okay, so happy Wednesday, everybody. Thank you for being here. It's a wonderful thing because I think it feels a little bit more like a weekly kind of palliative care family reunion or fortnightly thing that we do now, because I know most of you, which is lovely. Thank you for coming again. Before we get going, I'm going to do a quick acknowledgement of country, and then I'm going to introduce our speaker and our topic. So at PCNA, we acknowledge that we live and we work on the sacred lands of the First Nations people of Australia. Each person today joins us from a different land, and I'm joining you from the land of the Larrakia people. We recognise and we respect the sovereignty of these lands and that it was never ceded. And we acknowledge that the air, the waterways and the lands that we work on have deep significance for the First Nations people of Australia. We honour, admire and respect them, the Aboriginal and Torres Strait Islander people of Australia, who represent the world's oldest continuing culture, their strength, their resilience and their deep interconnectedness to all things ground us as we work. So thank you for joining us. And I have great pleasure to introduce to you Dr. Wei Lee. And Dr. Wei is a palliative care physician and researcher based at the Northern Districts of Sydney. He's the Director of Palliative Care at the Mater Hospital in North Sydney and a palliative care specialist at Hammond Care North and North Shore Private Hospital. So wave to us. There you go, there he is. Now, Wei is going to speak to us about depression and palliative care, which I think is a topic that all of us have come across, but many of us experience that no one really owns it, right? Like when we're in palliative care, everyone, oh no, that's the GPs or, yeah. So I think this is very timely and we're very excited to have Wei speak with us. Before we get going, if you are able to, please turn your camera on because it just helps us feel like we're not speaking to a void of black screens. Thank you. And turn your sound on mute. Thank you for those people that just turned their camera on. That is the best. And if you've got a question, pop it in the chat and I'll ask them at the end. We're going to have a little quiz at the end, so stick around and welcome and thank you, Wei.
Thank you, Sarah. Yeah, so my name is Wei. I usually work in Sydney. And let me jump into it and share my screen.
Yeah.
So,
And while you're doing that, the lovely thing about today is I don't have to do very much because Wei is going to present. And this was the presentation that he gave at the OPCC conference. So we're lucky us. Thank you, Wei.
and so can everybody see the slides okay? Give me a thumbs up if you can. Okay, great. So, yeah, today I'm gonna talk to you about depression. And so give me a shout if things are not working. And so, mind you, so depression itself, wait, how do I? Yeah, you can see the slides going forward then. So depression itself is actually quite a big issue that often has been unrecognized by a lot of people. So for the individual, in the New South Wales realm, people have a institute called Black Dog Institute that looks at mental health for the community. And depression is described as a black dog, like a lurking shadow, giving people overwhelming negative emotions. But importantly, when people get very depressed, they also start to be unable to function in their usual roles. And what it means is that they can lead to unfulfilled expectations if they are in a certain relationship. For example, they can't work properly, they can't become a parent they need to be, they might be neglecting certain roles of theirs or being parents, they can't necessarily care for their children that well. That can lead to different kind of relational tensions, and those who care for them can often also have their own mental health issues. And in the Australian community, the burden of disease for depression is actually higher than that of breast and bowel cancer, but oftentimes is not talked about. And in fact, in the world, it is the highest burden of disease posed in middle and high income countries at the moment, with the depressive disorder called unipolar depressive disorder being the leading cause of burden of disease in 2030 that is postulated, being higher than ischemic heart disease and motor vehicle accidents, which all have public health approaches, but in depression, this is rarely the case. Now, you may say, what do you mean by the word depression? Because in fact, different people mean different things. Like, let's say I have technical difficulty joining the Zoom calls. I feel a bit anxious. I feel a bit depressed. But that is not necessarily pathological. Whereas and pathological ones can often have a functional impairment to it. Or another bunch of people may say, well, actually, when I talk about depression, I'm not talking about a state of mood, but I'm talking about a syndrome where somebody has low mood with other kind of symptoms and signs, such as anhedonia, an inability to enjoy things that they used to enjoy, or psychomotor retardation, they feel so fatigued. And so people call this constellation of symptoms and signs different names, such as major depressive disorder. Um, Major depressive episode, which give you the syndrome and flag towards certain causes, but not necessarily tell you what are the causes. And it's certainly some people can actually depression meaning certain kind of disorders, which imply certain etiology, such as major depressive disorder or bipolar or adjustment disorder, which tells you these are the causes and this is how you treat it. So as clinicians, oftentimes when we are talking about depression, the word depression, we typically mean a syndrome or a disorder. Palliative care, as you are all in, is a specialty that focuses on improving the quality of life and comfort for patients with advanced life-limiting illnesses. And as many of you may have the experience of, is not a lot of your time is not necessarily dealing with end-of-life patients, and it's not necessarily also cancer. But there's people now living longer, and therefore there's a lot more nuance to the care of patients, and therefore depression should be a primary focus when we are talking about quality of life and how people perceive their well-being to be. In terms of the prevalence of depression, though, in the literature, you'll find that it varies throughout how depression is defined. If let's say I give you a questionnaire to say, let's go and do this questionnaire on your patients that you see, for those who fulfill a certain cutoff, then you say that they are significantly depressed. If you do that way, using tools, versus you ask the psychiatrist and go to interview all your patients using various diagnostic criteria, such as Diagnostic Statistical Manual or International Classification of Disease, then you can get varying or differences in their prevalence. Mind you, some people then say, well, if you say somebody's depressed, then it can include, let's say, major depression, it can include minor depression, and a lot. And that then, with the different kind of combination diagnosis, it also leads to different percentages. And so on the bottom right, you can see, for example, if we just talk about minor depression or major depression, over there, sometimes for major depression, it's like 1 in 6 in a healthcare population. But as you combine things, the actual percentage is higher. The other thing I want to flag is a lot of us will say, hey, if I have cancer, then it must be very depressing. However, rarely do people think about, let's say, if I have heart failure or renal failure, people don't think about depression. And in fact, in the literature, it's shown that the non-cancer cohort actually has a higher prevalence of depression than those with cancer. And that's something that we really need to think about, especially when we see cardiorenal patients, as well as those people with neurological disorders. What about those who are about to die when the life is getting shorter to only days to weeks range? Does the prevalence of depression symptoms increase or decrease? Well, to answer that question, because many people have different opinions to it, we did a systematic review. And what we found is firstly, as as deaths draw closer, the prevalence actually increases over time. And there is a significant proportion of patients that have new onset symptoms in the last month of life, even up to 57%. Now, when we do meta-analysis of these or the various studies, and on the right-hand side, you'll see that when people use tools or a questionnaire to try and diagnose clinically significant depression, 1 in 2 patients will have significant depressive symptoms. However, if they then get a psychiatrist to interview those patients, those with minor depression is only 5%. Those with major depression is only 10%. And you go like, well, hang on a minute. Does that mean those tools are too sensitive and not specific enough that they are over calling the shots? And very importantly is when we look at the low risk of bias studies, I had a study that actually looked at all the combined depressive disorders, including major minor depression, dysthymia, or mood disorder due to general medical conditions with depressive features. It actually come to all added together 47%, which simulate that using a tool called Hospital Anxiety Depressive Scale, which tells us these tools are actually really good at picking up people who are quite significantly depressed that needs intervention. However, at times we don't really know what is called. Like you may have a situation where you see a patient and you go like, oh, I see that patient and I feel this patient is very depressed. But then I call in a psychiatrist and the psychiatrist wrote like, the patient does not have major depression, but query delirium with depressive features or query adjustment disorder. And then other people will go like, oh, the patient doesn't have major depression, doesn't need an antidepressant. Oh, let's just, maybe we'll just monitor. Let's not do anything about it. The key point I want to raise is if you have a patient that you are concerned about significant depression or you score it as significant from the tools, treat that properly and intervene. And you can give medications because a lot of the times we might not have the name to call it major depression, but it is something quite significant still. Now, a lot of your patients have or they will reach a stage where their prognosis is very short, of only days to weeks left. And in this kind of setting, most of them will have increased dependence on others. Their functional status will reduce. For example, their Karnofsky Performance Scale, or AKPS, will be 40 or less. They will often have increased symptom burden, such as anorexia, cachexia, fatigue, pain, breathlessness, and even difficulty swallowing, and also having memory impairment. Now, this a lot of times is often associated with a loss of benefit of treatment from the underlying disease. For example, chemotherapy doesn't work anymore, right? And at the same time, they start to have renal and hepatic impairment with deranged lab results. So that all of these things then can contribute to the patient having adjustment issues, as well as thinking that they are becoming a burden for their loved ones, contributing to that depressive symptoms. At the same time, many of these patients will say, I've gone through so much. I don't want you to jab me with needles anymore. I don't want IV blood test or chemotherapy or transfusions. I find going out to clinic too hard. It's just too tiring. And at the same time, because of their breathlessness or cough or other things, right, they might also be on opioids, benzos, antipsychotic, which altogether have a heightened anticholinergic load and therefore the risk of delirium. which means overall, these bunch of patients, for you to assess and manage depression, this is much, much harder because, firstly, the progressive illness itself can cause tiredness, can cause slowness in movement and cognitive impairment. And that's really hard to try and tease out from depression causing the somatic symptoms, such as these things. At the same time, they, because of all the organ impairment, fatigue, and things, they also have reduced tolerabilities to interventions. Even psychotherapy, they simply just can't talk for 1 hour, for example. They can swallow the typical antidepressant, or even if you can give the treatment, that's such as an SSRIs and an antidepressant, oftentimes it takes more than a month to work. And you may say, well, there's not the time enough for the intervention to take effect because my patient is going to die in days. And overall, this is a dynamic changing processes that needs frequent monitoring, and it becomes very hard to figure out what can we do to the patient so that it's low burden and feasible, and at the same time can kick in fast enough to help the patients. So what are some of the risk factors for depression in this setting? Well, a lot of us might have contacted or have the experience of having patients that is young, cancer, with especially female, like female mom having children. And a lot of times they will say, I want to keep living for my children, for example, I want to keep pursuing all the treatments. And you'll find them having a lot of psychoexistential distress, which makes things very hard to treat. And it may say to you, I don't want too much opioid because otherwise it make me drowsy. And at the same time, because of that, they have uncontrolled symptoms and pain. And it just makes everything so hard. Certain kind of illnesses also have heightened risk factor of depression. Things like pancreatic cancer, head and neck cancer, lymphoma, people with tumors in the brain, and very importantly, hypercalcemia. Symptoms of hypercalcemia doesn't just have constipation, tiredness, but depression is one of the symptoms of hypercalcemia. People with paraneoplastic syndromes can also have that. Depression as one of the other signs. Non-malignant disease, though, a lot of people with chronic pain, especially with central sensitization pain, has this problem. Ischemic heart disease, heart failure, hypothyroidism is well known to do that. Neurological disorders such as Parkinson, motor neuron diseases have high incidence of depression, and those with HIV infection and substance use disorders. Now, a lot of our medical treatment also can pose risk factors to depressive symptoms, including steroid that we use can give a high as well as a low. Those people with liver diseases can be on interferon or propranolol. That can also known to induce depressive symptoms. Hematology patients antifungal such as amphotericin, as well as other anti-systemic anti-cancer therapies such as methotrexate can also do that. And lastly, a lot of us have patients that undergo brain radiotherapy and head and neck radiotherapy. That's also itself a risk factor to depression. Now, I want to show you this pathogenesis of depression. Apart from the serotonin pathogenesis people talk about, this graph shows how there's different kind of inflammatory cytokines, such as IL-6, TNF alpha, that we're all very accustomed to in the uni world to talk about inflammation. And you'll see that these inflammatory cytokines are actually secreted by cancer or other kind of inflammatory underlying diseases, which actually go into the limbic circuits of the brain and influence your mood. Simply put, depression actually is an inflammatory response in the medically unwell patient. And what we're trying to drive is this idea that medically unwell patient, when they get depressed, is actually an organic affective syndrome. It's not the same as simply not coping. And you can use this to your advantage when you are talking to, let's say, macho Australian men who says, I can't tell you I'm depressed. It's a sign of weakness. And I'm not weak. And you say, no, no, actually, if you get depression symptoms, anyone with medical illnesses can do that, just like you get a cold or flu, because you have inflammation going on. And just like if I don't sleep for 4 days, then I'll have certain symptoms. And similarly, depression can be treated. It's a bodily symptoms that needs intervention, even sometimes medications. So what about our clinician, our colleagues? How do they approach depression in this healthcare setting? we actually conducted a survey and a focus group for both palliative care physician as well as clinical liaison psychiatrist, and as well as a broader group of psychiatrists around Australia and New Zealand earlier on. And we found that only 40% of clinicians screen for depressions in those who are about to die with only days to weeks left. This is contrasted with both psychiatry and healthcare clinicians who screen much more, even up to 70 or so% for those who are otherwise well in the healthcare population. Everybody mentioned that they have different kind of practices. For example, when it comes to somatic symptoms of depression, such as fatigue, the psychomotor retardation, sleep changes, appetite changes, people talk about differences in whether or not they include or exclude these symptoms, especially when the prognosis are shorter. Importantly, 100% of clinicians says they didn't know whether or not what's the cause of the depression at times when they see these patients who are about to die. But disturbingly, interestingly, is for those clinicians that says that they see people who are about to die, they say they are much less likely to intervene for major depressive disorder using either non-pharmacological intervention or pharmacological interventions should they know the patient is about to die. Because a lot of people may think or hypothesize that if people are about to die with depression, people might just quickly jump in and treat it, but it's actually the opposite. A third of the clinicians says they do not use psychostimulants, and two-thirds says they don't use novel or new medications such as ketamine, esketamine, or experimental trials. When we asked them in the survey followed by focus group interviews and focus group setting, people talk about different barriers of depression care in this population, and the overwhelming theme is it's just too complicated. Like it's so complicated to know what is normal and what is abnormal, what is the somatic symptoms of depression versus that from the terminal illnesses? How can I differentiate between depressive disorders versus demoralization versus delirium versus other things? And if I give the medication, it just doesn't work in time, or it's just too much burden for the patient, they can't swallow, or they're just too tired, they have low sodium, they can't get this drug. And importantly, a lot of people also say, well, they just have too much physical symptoms that I can't have time to prioritize psychological symptoms. There's interestingly a very strong sense of nihilism among clinicians, saying literally many people will literally write this phrase of what's the point of screening or assessing if there's not much I can do about it. Others will say, isn't it normal for people to get depressed before they die? And therefore, later say, then therefore we shouldn't intervene because it's normal. If I intervene, it might cause harm to the patient that they don't talk to them or they don't talk to their family about it anymore. So therefore, a lot of clinicians actually have ambivalence about assessment and treatment of depression. And some says, well, this field is so not well studied. If I do treat the patient with some kind of new drug, then I will be bombarded by my colleagues saying I'm doing something like a cowboy. And they have fears about intervening, while patient says, ooh, mental illness, there's a stigma to it. I don't want to disclose it. All right. So overall, there's so much attitude problem and cultural change that's required. And at the same time, there's a lot of communication challenges. Patients too frail to talk for long. There's a lack of cholesterol past history, especially when people get admitted. Language and cultural barriers are especially prevalent in certain settings. Clinicians feel like there's a lack of training. So most healthcare clinicians says they don't have much mental health training. But interestingly, psychiatrists also say they don't have much healthcare training. So to them, they fear seeing healthcare patients. And they also say this idea of transparency and counter-transparency. I don't want to see that patient because that patient simply just make me too sad. I'll try and avoid it. Right. So overall, the service will say there's a lack of staffing. We don't have the money and the time. We don't have the access to the required interventions such as cognitive behavioral therapies, all the medications, and not even the private space to talk about it in the two-bedded ward or four-bedded ward. And lastly, there's not much guidelines to guide the whole treatment trajectory. Overall, when we quantify the themes, the biggest problem, however, lies in this clinical complexity realm, which I'll talk to about more. So in the Greek mythology, my computer is freezing. So the Greek mythology wise, we have black dog, a black dog, three-headed black dog called Cerberus, which is the hound of Hades that guards the gate of hell, and that stops the living and the dead from going across one side. We as clinicians often feel like we want to be the hero who can fight the depression black dog. We can win over the war, and we can just tell the patient, hey, you're depressed. Don't worry about it. We can just assess it and treat it, and you'll feel all right again. But a lot of times in reality, that's the opposite. We often feel like hiccups, that main character in How to Train a Dragon feel like, I'm so scared. I feel I'm so overwhelmed like this. I don't know what to do. And in fact, when we ask in a focus group, a number of not patients or clinician participants literally say, I feel depressed when I'm seeing patients in this field, and there's too depressed to talk about, which is a very interesting thing. So we're going to talk about an approach tackling depression in the dying, and we published this, and we call this a screening approach. So firstly, the whole assessment is just like any other symptoms. Screening is still recommended in the healthcare setting. We try and assess patients to diagnose depression, and we assess for potentially reversible causes and contributors, including pain, hypercalcemia, life and relationship stressors, and loss of meaning. And then we assess for the severity and complication and risk to patient and others. So there's so many ways to do it, but remember, you always can get help from mental health specialists if required, even though I know that access has been an issue for many, many services. Now, screening should be carried out in all healthcare patients. We can consider the use of screening tools to help, and there are in the world around or more than 50 types. But the key is being practical and feasible while we yield a valid, trustworthy result. So on the left-hand side are what we call generic tools, where things like Edmonton Symptom Assessment Score or the PICO tool, which is, by the way, gonna switch likely into ESAS in the future. But include pain, nausea, fatigue, that kind of things. One of the item will be depression or anxiety, and you just score it from 0 to 10. That's called a generic score. The other kind is more depression-specific scores, like hospital anxiety depression scale. And then a lot of GPs use that, for example, and you get your patients to go through anxiety and depression scores. And however, many people will say those kind of things are a bit too hard to achieve. So a psychiatrist in Canada called Harvey Chochinov actually devised what we call an ultra-short questionnaire, um, which is tested in the healthcare population and validated. So in fact, just saying the single question of asking patient, are you depressed? If the patient says yes to that question, yields a sensitivity of 72% for major depressive disorder. Sorry, just the call is coming. Just gonna mute that. So that would have a sensitivity of 72% to pick up major depressive disorder with a specificity of 83. And you go like, that might be a bit too non-specific. That's true, that's true. But then if you ask, have you lost interest? Also, is as a single question, the sensitivity and specificity improves. If you actually ask the two questions together in the consultation, the sensitivity for major depressive disorder pick up as high as 91% with a really good specificity of 86. So what a good way to approach this is when you're talking to your patient and building up rapport, a lot of us will ask, hey, what's important to you in your life? What's your hobbies? What do you like doing? After that, you can ask them, have you lost interest? If that's all the time you have. If they say yes, then that's a red flag to think about going further in depression assessment. If you even have more time, you can ask, are you depressed? And if they say yes, and you go like, aha, I need to do more and dig down a bit deeper. Following this, computer frozen, sorry guys. We're gonna go into depression diagnosis.
Is it working?
Can you guys see? Okay, great.
You're
So
doing your
depression
job.
diagnosis. Yay. So essentially for the non-psychiatrist clinicians, oftentimes we use tools. So we often will use, for example, the HEADS tool or the patient health questionnaire tool. Overall, these ones, once the patient reaches a specific cutoff, then you can diagnose them with clinically significant depression. However, some people will say, oh, this is too burdensome for patients. Yeah, that can definitely be. Another way to go about it is rely on your consultation or another clinician's consultation and match that to the diagnostic criteria in the in diagnostic statistical manual or the international classification of disease. Now, these diagnostic criteria are the gold standard, which do need you to interview the patients. And don't be afraid of using them, even though you are not psychiatrists. But you can look at those criteria and have a think about what may be the disorder or the cause underlying that depressive symptoms. And if you're not sure, refer to mental health clinicians. Now, I'm going to go through various type of depression because there is a big range of them. However, out of all these ones, I want to flag to you that you just need to be able to pick up those that needs pharmacological interventions. Now, there is major minor depressive disorders. There's like depression due to another medical conditions. There's like substance medication-induced depressive disorders or dysthymia or persistent depressive disorder, right? All out of all that, they all have slightly different depressive disorder diagnostic criteria. But if you have a patient that has melancholia, right, which is characterized by psychomotor retardation or slowing, because a lot of us will just say, oh, the patient is just too fatigued. It must be from the cancer, which may not be the case, right? At times, it may be actually because of the depressive disorder. Or they get psychomotor agitation, and we go like, oh, the patient has hyperactive delirium, which there's ways to tease it apart. And these kind of patients can do really well with antidepressants. Similarly, for those patients that has psychotic depression, that has delusional hallucination, they also do really well with pharmacological therapy. And occasionally, if they are more like a geriatric population, people actually think about electroconvulsive therapy for them. Whereas those patients with mild to moderate depression without melancholia or psychosis, right, many of them can be best treated just with non-drug therapy and can be at least initially managed in palliative care setting. You may ask, how do I tell whether or not this depression is a normal response or abnormal response? Let's say I get told I have a life-limiting illness and I likely will only have a few weeks left. Well, the likelihood is I will feel quite sad. I will likely resign from my job and I won't give this talk. And I will be telling my family, say, hey guys, please let's spend much more time together. I got this diagnosis, time is short. My kids and my wife will say, hey, let's do something fun. Let's go on holiday. Let's watch movies, things that you love. So while I'm doing those activities and watching the movie, I might completely forget that I have a terminal illness. And I will enjoy myself. I will look forward to those things that I love. But then after those kind of social engagement and doing what I love, while I'm alone, for example, in bed, sleeping at night, or about to sleep, I might just remember the terminal illness and go like, oh, I feel sad again. So that feeling of sadness can come as a wave and it can fluctuate. But very importantly, I still retain the ability to enjoy happy memories, to connect intimately with other people around me. I can still look forward to things. I have an intact sense of self-worth. I know my life has had values. I might want to create a legacy for my children, for example. And I may have a passive wish of that, saying that if I get pneumonia, don't treat me because I've lived a good life. But that's quite different to me saying, actually, I used to love hanging out with my kids and my wife. Now I don't want to anymore. I don't care about the movie anymore. I don't care about the things I love. In fact, I have no interest. Even if you take me to the movies, I don't feel any joy in it. And then I have this constant unremitting feeling of negative mood that it just does not fluctuate. It's just always there. And that tells me that I want to end my life. There's an intense, persistent suicidal ideation. That's totally abnormal. So just keep this analogy in mind, and you'll be able to tell what's normal and abnormal a bit easier. What about the somatic symptoms of depression versus that of terminal illness? Because people talk about depression itself can cause fatigue, sleep changes, anorexia, weight changes, and that's the same as terminal illnesses. So a lot of people will say when we are actually assessing and diagnosing the patients, then we can focus a bit more on psychological and cognitive symptoms such as worthlessness, hopelessness, guilt, and thoughts of self-harm for diagnosis. However, when we're thinking about management, because a lot of our patients can have anorexia, for example, from both depression as well as, let's say, cancer. You still will need to assess the somatic symptoms so that you can manage that and optimize these kind of physical symptoms. Now, one of the ways to deal with this confounding effect of the terminal illness on somatic symptoms of depression is using a substituted diagnostic approach called Endicott criteria, which is this. Um, for example, using ethical criteria, it lists down on the left column 9 items for diagnosing major depressive disorders. And out of the 9 items, such as depressed mood, anhedonia, which is the second one from the top, weight changes, sleep changes, psychomotor retardation, or agitation, 4 of them that was highlighted are the somatic symptoms. So Gina Nicole, a psychiatrist, changed these 4 items into other melancholic features of depression, such as depressed appearance on the right, social withdrawal, decreased talkativeness, brooding self-pity or pessimism, and the lack of mood reactivity, that they cannot be cheered up by things that they used to cheer them up. So if you actually have patients that matches criteria of 5 or more items, despite them having, let's say, metastatic cancer, for example, they actually can be diagnosed with major depressive disorder by this criteria. The beauty of this criteria is it include objective items that for patients who are severely depressed, that they lose their insight, you ask them, are you depressed? And they're so depressed that they will say to you, no, I'm not depressed, because they are not recognizing they are depressed. But you ask their family, are they depressed? And they go, oh, so depressed. They used to be so cheerful at the dinner table talking. Now the person doesn't talk anymore, doesn't engage with us anymore, and just crying, or appears sad. So the objective icons become so useful because it can be a functional measurement. On top of that, because it flagged to you people with melancholic depression, it also tells you who are more likely to benefit from pharmacotherapy. So the next thing we need to do is when you see your patient with depressive symptoms is considering the differentials that include demoralization, delirium with depressive features, and pain and other symptom-induced distress. Other things to really also think about is the endocrine panel. Do they have hypocalcemia, for example? Are they low in sugar, for example? All they need is a bit more jelly beans. Are they anemic that they need transfusion, or are they having hypercalcemia that you can treat? Or are they have medication-induced problems like from high-dose steroid because of hematology treatment, for example, dexamethasone 40 milligram, and other kind of CNS diseases that we also need to think about. Demoralization is a very important differential to consider. It is different to major depressive disorder, but it can happen at the same time. It is an idea of a patient having a low morale and having difficulty coping because of that illness, where they feel, for example, pointless, meaningless, that they are hopeless, they feel they are trapped in the body, and they have this reduced sense of self-worth. And because of that, they feel like are better off that they just die. The suicidal risk of having demoralization is actually higher than that of major depressive disorder. But the very important thing about this condition is that the treatment is not by medication, but it's by talking therapy, things like dignity therapy, things like meaning and purpose therapy, that you try to help them recenter their meaning and purpose so they have a sense of worth and meaning in their lives. But it does, and it can happen at the same time as major depressive disorder. The next thing after you diagnose depression, so screening, diagnosis, then you assess severity. Now, many people then say in the literature, well, let's do a score, let's do another questionnaire, and you go like, oh my gosh, I've done a screening questionnaire and then diagnosis questionnaire and another like 20-item questionnaire. The patient just feel, oh, this is all a bit too much. Maybe another way of doing so is find a patient-specific functional goal that is meaningful for the patient and their family. For example, if they say, I used to love to do hiking with my family, use that as your functional goal. Or I do like to go out a date with my wife, a social date, and now I'm so depressed I don't do that anymore. Then use that as a goal to figure out the severity and as a treatment measure whether or not to see whether or not treatment is working. Importantly, we do need to assess their risk of self-harm. And to do so, we do at times look at means of harms, right? But if you do have a patient that presents immediate danger to themselves, do arrange an urgent referral to specialist mental health services, even though we know at the moment there is a lot of issues where for patients who does not have healthcare needs, who just have mental health problems and have high risk of harm, people send them to mental health units. Versus when patients don't have mental health mental health issues, and they are dying with healthcare needs, we send them to healthcare units. But at the moment, we don't yet have a unit that merges the two. So oftentimes we do have to send these kind of patients to an acute hospital where you can get both healthcare and mental health input urgently for now. In the future, hopefully that will change. Now, in terms of management of depression, it's just like the other symptoms. Beware of the sense of nihilism and futility because major depression can still be treatable even in the terminally ill, right? Involve the multidisciplinary team setting, the pastoral care, the social work psychologists, even the GPs, plus or minus mental health service, if you can get some. But do treat the potentially reversible causes such as pain, hypercalcemia, hypothyroidism. The non-pharmacological interventions is the foundation. Giving pills to them is not the way to go all the time. And so on top of that foundation of talking therapies, and pathetic listening, consider pharmacological intervention, and even consider experimental trials, which I'll talk about more. Things to think about is what's the prognosis of this patient? Because if the patient is going to die in days to weeks, for example, less than 2 months, then we have to consider medications early. So usually, for example, we do have a low threshold to start medications in the GP land. Now, you will oftentimes depressed patient go and see the GP, for example, they will say, hey, let's talk about why you're feeling depressed. Let's do this and that. Come back again. And then if that is not working, we'll see a psychologist. If that's not working, then we'll get you on medication. And then we'll have a trial of the first line medication, wait for 3 months. If that doesn't work, I'll give you a second line agent, wait for another 3 months. So the definition of treatment-resistant depression is 2 courses of treatment, which takes around 6 months. If your patient is about to die, don't do that. So do start the medication early, even if depressive symptom is questionable according to the guideline, and lower the threshold of treatment-resistant depression to only 4 weeks. And importantly, in up-to-date recommendations, it will say add on a rapid onset intervention such as methylphenidate, or the brand name is Ritalin, to typical interventions in case the patient, just in case the patient live longer. But you need something that works really fast so that it can work in time before they die. Think about coexisting symptom burdens such as neuropathic pain, anorexia, insomnia when you choose your weapon or target. And then beware of antidepressant discontinuation syndrome because your patient before they die likely is not able to swallow typical antidepressant. And lastly, notice all interventions are experimental in nature for people who are about to die. Now, you may say, what do you mean by that? When we did a systematic review, hoping to look for the magic bullet for depression, looking into more than thousands of randomized controlled trials in the world for all the interventions, including cognitive behavioral therapy, any kind of talking therapy, and medications, we found that there's 0 randomized controlled trial that included people who are about to die in a way that is reliable and extractable. So what it means is all interventions, whether or not it is duloxetine, mirtazapine, or whether or not it's dignity therapy, everything you were talking about is actually in a way that you don't know whether or not the patient will respond good or bad, right, to it. So whatever you initiate, to exercise caution and essentially start either a low dose, but quickly upgrade the dose and then just check on the response, both good and bad, to decide how you should titrate or tweak it. And for researchers, therefore, we do need to have more inclusive and feasible design other than just the usual conventional randomized control trial. 50% you'll get placebo, and the patient goes, I'm about to die. I do not want to join. Yeah, if that makes sense. So the non-conventional, the non-pharmacological intervention, commonly things like on the left-hand side, cognitive behavioral therapy, problem-solving therapy, self-help intervention, life review, dignity therapy, and forgiveness therapy. There are so much of them that has strong evidence with systematic review evidence saying that it works for even moderate to severe depressive disorders. Whereas on the right-hand side, there are much less evidence. So things like exercise, music, massage, spiritual interventions, group reminiscence therapy. It's not to say that they do not work. They actually have system like level 1 evidence that it helps improve depressive symptoms, but there are not enough evidence to say they are useful to treat major depressive disorder that is moderate to severe. And what it means is that we firstly need to, for these non-pharmacological interventions, because the whole full course treatment is usually 6 to 8 weeks, and it takes time for that to kick in, we have to modify these interventions to match the need of our patients. If our patient is too fatigued and too frail, then rather than a 1-hour talking therapy, change it to 30 minutes or 20 minutes, right? And then think about which one of them are rapid onset. Out of all that I mentioned, there's only at the moment with the the trials we have is light review and dignity therapy are found to have a really rapid onset effect, like within days, people's depression actually can get better. Then you can think about combination approaches, like using, like let's say, cognitive behavioral therapy with mindfulness plus art or music therapy, or adding some psychoeducation, or even combine these with pharmacological agents, so to overall improve the well-being of these patients. In terms of medication-wise, we'll go through typical antidepressant, psychostimulant, electroconvulsive therapy, and experimental therapy. The key consideration I want you to get into the head is that when you're choosing your weapon, think about the effectiveness, the tolerability, the side effect profile, and the access of these interventions. So, firstly, in terms of the pharmacological intervention, somebody in 2021 called Singhi, they published a systematic review that they look at all the various kind of interventions for the palliative population and found that out of these, the rapid onset antidepressant include methylphenidate, ketamine, and psilocybin. And by the way, these are the ones that people in Australasia rarely prescribe. Now, let's go back to typical antidepressant because that's what we typically prescribe. A lot of times we like to give monotherapies, select single agents. And in fact, in the community setting, a lot of the times with geriatrics or GP land, people get put on an SSRI, right? Which is serotonin, selective serotonin reuptake inhibitor. Now, however, if that doesn't work, a lot of times that then get upgraded to an SNRI or serotonin noradrenaline reuptake inhibitor, which has dual actions. And things like that would include duloxetine and venlafaxine. Now, importantly, is if that doesn't work, a lot of people or clinicians then would upgrade it to tricyclic or tetracyclic. Importantly, is you do not have to follow this stepwise approach, but it's important to consider the particular needs of the individual, which I'll talk about more. If your patient still have breakthrough depressive symptoms despite on a single agent, you can consider a combination approach, which at times is called California rocket. So things like, for example, using a tetracyclic such as mirtazapine with a SSRI or SNRI like duloxetine can be used. So if you have a patient, let's say, who's already on SSRI or SNRI, and they are still quite depressed, and they are about to die, you might not have the time to change into a different antidepressant to slowly wash out, so slowly cut down the dose, wean it off over days to weeks, and then start another new agent over days to weeks. So what you can do then is consider this combination approach early while they are on, like for example, an SSRI. You then say, I'm gonna add in a baby dose of nortriptyline or a baby dose of mirtazapine while I continue to monitor for serotonin syndrome much more diligently, because they do have a higher risk of serotonin syndrome if we do that. And in that way, you can get the efficacy much faster and without wasting time. So I'm going to go through the various categories of the common categories of antidepressant. For example, the SSRIs, it can be well tolerated in the palliative setting, we know. Sertraline, for example, is a common one, and it is very useful, sertraline, in cardiorenal patients. In fact, it's quite safe for that kind of patient. I put the dosing in the brackets for you. Meanwhile, citalopram is actually very safe for patients with seizures because it doesn't lower down the seizure threshold that much compared to other ones. If you need a medicine that is able to be swallowed as liquid, then escitalopram is the only one available in Australia that you can swallow. However, overall, SSRI, their use can be limited in in a lot of healthcare setting because it does not help with neuropathic pain. It doesn't help with things like insomnia and other kind of symptoms directly. And also, if you have a cancer patient who are on hormonal therapy or certain chemotherapy, SSRI can interact with them. For example, the paroxetine, it can interact with tamoxifen for breast cancer and actually cause reduced survival. Or with irinotecan, it can cause diarrhea. And therefore, we tend not to use that. Now, the next line of treatment you can think about is an SNRI, things like duloxetine and venlafaxine. Importantly, they help with neuropathic pain, even though, however, a quarter to a fifth of them may also experience nausea. The geriatric world or the psychogeriatric clinicians, they like to use venlafaxine because it may actually be better for depression, and while it has a very larger increments till the max dose. So you can start at the dose of 37.5 and gradually tweak the dose at smaller increments to 225 max dose. Versus duloxetine, you have only 4 steps from 30 milligram to the max dose of 120. So it's a bigger jump each time. However, the problem with venlafaxine in a healthcare setting, unlike geriatric, is many of our patients, before they die, they can't swallow. And venlafaxine has much shorter half-life. And therefore, if you can't swallow venlafaxine, you will have much higher risk of antidepressant discontinuation syndrome. So a lot of the patient who's on venlafaxine, we actually have to, for example, add on mirtazapine, for example, or something else that when they can't swallow, they can still continue to have the antidepressant effect without withdrawing. The third thing is tricyclic. So things like amitriptyline or nortriptyline, they can definitely help with neuropathic pain. In fact, they are the best out of all the antidepressant in helping neuropathic pain. However, they do have tolerability issues. Things like because sedation risk of amitriptyline, liver impairment, they can have orthostatic hypotension, increasing risk of falls and dry mouth. If you still have to use it in your patient because of the coexisting symptoms they have, you can think about switching amitriptyline to nortriptyline, which is an active metabolite of amitriptyline, which can improve the tolerability of this drug. And the dosing conversion is 1-to-1 conversion if the dosing of amitriptyline is 100 milligram or less. Or you may say, if they can't tolerate tricyclic, then just change it over to duloxetine. Lastly, the class of medication is called tetracyclic, and in Australia we have mirtazapine. So mirtazapine is an interesting drug. It has many targets, and so because of its, for example, 5-HT3 target like ondansetron, it can help with nausea. Because of its antihistamine target, it can help with insomnia at a low dose. It can also improve people's taste from chemotherapy. And then there's case series that says it can help with breathlessness, but in randomized controlled trial, it can't. The effectiveness of tetracyclic or mirtazapine is better than SSRI, and very importantly, is while the efficacy is comparable to tricyclic for depression remission, nonetheless, it has a faster onset of action than tricyclic, which out of all the antidepressants, this one only takes 2 weeks. Other ones typically is 4 weeks in the healthcare population. There's not an associated cardiovascular risk factors nor sexual dysfunction. And very importantly, it has a sublingual wafer form, while others do not. Others have to be swallowed. Note, however, at low dose, it is an antihistamine that makes people drowsy. At a high dose, it becomes a noradrenaline reuptake inhibitor, make people more energetic. So if your patients are drowsy at low dose, then you quickly increase that dose. And lastly is just if your patient is on warfarin, it does increase the anticoagulation effect than INR, so you have to repeat the INR and go about checking it. I'm going to go into the other agents. So psychostimulants are things that make you or stimulate your CNS system, make you having elevated mood or alert with more energy. We all have it, like tea, coffee, they are common, they are caffeine. Other same class of drugs include nicotine in cigarette, cocaine, as well as amphetamine derivative, including ecstasy, the love pill that help people enter an empathetic state, and therefore people would like to use it for party drug to help them socialize. And then there's 2 other drugs that I'm going to talk about, including modafinil and methylphenidate. Firstly, modafinil is a non-amphetamine-based psychostimulant. In typical antidepressant usage, because sometimes antidepressant can cause actually drowsiness as well as neurocognitive slowing as a side effect, it's found that if you use modafinil, not only would you reduce that drowsiness or neurocognitive slowing, you also augment the antidepressant efficacy, increasing the chance of remission of depression. It also can help with opioid-induced drowsiness. So let's say if you have a patient who's on morphine or oxycodone, they get drowsy, they can pop on a little bit of modafinil, they won't be as drowsy. If they have a stroke in the past and just after stroke, they often may feel quite fatigued. Modafinil in an ICU setting has been found to improve neurological recovery post-stroke. In the cancer setting, much less. So randomized control trial against placebo are all negative for cancer until you have a network meta-analysis bumping the sample size to more than 2,000. Then modafinil become useful for fatigue, for cancer fatigue. So just to know that modafinil exists, the dosing is 50 milligram to 400 milligram a day. Use it a bit like dexamethasone, like mane midi dosing to help your patients. The other one to really think about, which has much stronger evidence than modafinil in helping depression, is methylphenidate or Ritalin, which is used in ADHD children. In the guide, in a recommendation from UpToDate, in the last few years, it says, well, if you have a patient with a prognosis less than 2 months, think about using this as an adjunct or add-on to the typical antidepressant. In the past, we have general concerns around, well, this is an amphetamine-based drug. Do you have a risk of dependence or abuse? Can you actually tolerate it in a healthcare setting? Does the heart rate just go haywire with arrhythmia? So systematic review has been done to say that it's well tolerated. Now, after that systematic review is done, however, there's more randomized control trial that came out and showed that it is actually helpful for depression much more than even cancer fatigue, where cancer fatigue, it has a limited role, but for depression, it has a very robust role even in a randomized control trial setting against placebo. With an onset of antidepressant action rather than 1 month, it's actually 3 days. The dosing is half a tablet to start off with, which is 5 milligram, and you can increase it over time to 40 milligram a day. Split dosing, just like dexamethasone, for example, 5 mane for 3 days, then 5 mane midi for 3 days, and go up until you reach your functional goal. It's contraindicated if you have, for example, serious heart arrhythmia problem or structural heart abnormality where you might need some beta blocker for. It can help with opioid-induced drowsiness. And it works really well if you add in mirtazapine in the clinical trial, where in the morning you get methylphenidate to boost up your mood and energy, and at night you use mirtazapine to help you sleep, and all of them together work to improve depression much faster. Now, antipsychotic is in the last few years, we have used it much less because of the delirium trial we did, saying that in delirium, antipsychotic not only does not help delirium, but it also it causes reduced survival. However, this is quite different in depression, especially psychotic depression. So if you have a patient with depression and you add antipsychotic, it actually improves depression control much, much faster, and they achieve remission faster. It is also very useful to use antipsychotic to treat anxiety because typically we know how to use lorazepam. But for people who are on lorazepam or clonazepam for quite a while, more than weeks to months, they start to develop tolerance. And so to mitigate that, you can switch lorazepam to things like olanzapine or quetiapine so that they don't develop tolerance while treating anxiety and augment the antidepressant for depression. Importantly, things like olanzapine can also help control central and chemo-induced nausea and improve anorexia. In fact, it became the drug to help anorexia in the Journal of Clinical Oncology from last year. It can also be administered, not just IM formulation, but sublingually and also subcut. So it become a very, very useful thing and keep watch of the space. Electroconvulsive therapy or ECT is considered as the most efficacious intervention for treatment-resistant depression, but also in the healthcare setting, a lot of times considered too invasive with a stigma related to it. There's a risk of general anesthetic, which many of our patients cannot tolerate, and a risk of worsening cognition, and therefore is rarely administered in the healthcare setting unless people are living much, much longer. Now, we also in the media now talk about psilocybin a lot, and which is made from a thing called magic mushroom, sounding pretty cool, called psilocybin. And this medicine is oral induced, and it gives you a mystical experience where you go into your subconscious and dig down, why are you feeling this way? So a lot of times, a lot of you may say, oh, I feel bad, or I feel agitated, or feel depressed. And people ask you, why do you feel like that way? And you go like, I don't know. I'm not sure. And so if you go and see a psychotherapist, you might actually go and see a psychotherapist for 5 sessions. And the psychotherapist feel like, I just can't dig in deep enough into why you are feeling this way. And so a lot of psychotherapists find if you can put in psilocybin, where you go deep, deep down into your subconscious and bring up everything that is underneath the iceberg up so that you know why you feel this way. They are much it's much easier for them to talk about with you the issues that's driving the depression, and the depression treatment become very, very effective. In fact, the antidepressant effect of psilocybin when used together with psychotherapy, onset of action is only 1 day, and it lasts for 6 months, which is really, really cool, and is tolerated by even healthcare patients who are otherwise ambulatory and otherwise well. But very importantly, this is very intense because you are digging down all the subconscious stuff. And many patients without psychotherapy, they will feel so agitated because they will start to experience things from, for example, their traumatic past that leads them to have that kind of mood. So unless your patient is relatively robust and can talk for hours and hours with psychotherapists, they likely won't be able to handle macrodosing of psilocybin. Whereas there's another thing called microdosing psilocybin, where they give 120 to 130s of the psilocybin, hoping to not give you that kind of mystical experience. And that at the moment is still under investigation for depression. Now, lastly, I'm going to finish off with the drug called ketamine. So it's a medicine that we used in anesthetic called NMDA antagonist. And it's found that by accident, this drug, if you actually give it in anesthetic while you're having electroconvulsive therapy, it really improves depression. And then people then start to test it out and realize even if you don't use it with electroconvulsive therapy, it rapidly improves somebody's mood. And it is on par or nearly on par as electroconvulsive therapy. But the onset of action is even within 2 hours to improve somebody's depression, even against treatment-resistant depression in otherwise well psychiatry patients. And however, the issue is that this effect seems to be short-lived if you only give single dosing of only 4 to 7 days. And nonetheless, unlike a lot of other kind of antidepressant, which has an initial increase of suicidality in the first 2 weeks for typical antidepressant, ketamine doesn't do that. It just rapidly reduces suicidality. The mechanism is not because of serotonin, but rather is to try and help with the neuroplasticity of the brain. Because you might have the experience where if you have a friend who is very depressed, they will talk with you for ages about their depression, and you then give them some guidance. You think you've done a great job. The next day you come and call them up again, and to your surprise, they will talk about their depression again as if nothing had changed or nothing happened. And you go like, what? You haven't changed your thinking? Why are you so stubborn thinking about the negative thoughts? Ketamine changes that. It gives you the ability to think about new ideas and make thoughts able to come in, right, through the brain-derived neurotropic factor on the right column. But there's a question about whether or not we can do that in our healthcare patients because they might not be able to tolerate it. So therefore, what we did is we did a study and we start at a dose that is 1/5 of the typical psychiatry dosing of only 0.1 milligram per kg over 2 hours to look at in major depressive disorder patients with healthcare needs, whether or not they are able to tolerate things and whether or not they do have that antidepressant signal and whether or not we should go on to a definitive trial. So this is a graph with all different kind of colors. Each color is one patient. So we did in this feasibility trial went through 10 patients, and the upper graph has what we call MADRS score. The higher the score, the more severe the depression. Somebody there's a few patients was so severe that they barely could move and was admitted to a healthcare unit for end of life care, thinking they will die within early days. And so we gave them ketamine because they were also quite depressed. And as you can see, over time, these patients have a reduced depression score. On the bottom graph, the percentage change from baseline, you will see that most patients will have an onset or a drop of their depression score within 6 hours of ketamine commencement. But that duration of the improvement lasts only for days after each dose. Over the whole study course, 5 out of 10 participants achieved what we call a positive response, which is defined by more than 50% reduction of depression score. 3 achieved complete remission. However, after we stopped the trial, or stopped the trial drugs for them, 2 of them relapsed, saying that ketamine is not a long-acting drug. If we look at the data differently, we'll see that in the week that patients are getting ketamine, 50% of them reduce their depression score by more than 50%. However, it only 20% of these patients sustain response at 1 week later. If we then take away the somatic symptoms or bodily symptoms of depression, such as anorexia, sleep problems, and stuff, that actually improves their performance more. But I want you to notice the suicidal ideation item on the right-hand side. 90% of patients who have high suicidality improve their depression score by the suicidal ideation score by at least 50% in a week of getting ketamine, and 70% of them have a sustained response even on day 7. So this becomes a drug now a lot of people in psychiatry is talking about for suicidal ideation with depression, essentially. Now, so therefore, this is a developing field. There's a few trials going on, including an intranasal one that has been published, and also a pilot phase 2 randomized control trial with IV infusion at the moment showing efficacy of ketamine, if even better than placebo in the advanced cancer palliative population. However, if you read systematic reviews, they only included not clinical trials, but only case report and series, and therefore many of them won't be able to guide you about what to do. We know that there is strong antidepressant signal there with rapid onset symptoms within hours to days, but however, they are transient by single dosing. Nonetheless, they are really good at rapidly reducing suicidal ideation. Therefore, we know that with some literature, we need to have repetitive dosing, for example, 2 or 3 times a week for better outcome. We also know, unlike the pain dosing, where the ketamine becomes intolerable with a lot of confusion and neurocognitive psychotomimetic side effects, if you give ketamine a very, very low dose, then it is well tolerated. You actually can even spare psychotomimetic or dissociation side effects. And importantly, a lot of our patients have low blood pressure because of how sick they are. This drug doesn't drop your blood pressure, rather it increases slightly. So you can start on a very, very low dose, such as 0.1 to 0.2 milligram per kg over 2 hours through a syringe driver to spare those negative side effects. For example, that would be a rate of 50 to 100 milligram per day driver, but only apply it for 2 hours for 40 kilogram patients. And that is very, very different to the pain dosing of 100 to 700 milligram a day, where a lot of side effect happens. At the moment, well, in the literature, we don't really know what is the optimal dosing or routes for palliative population, because we know in psychiatry, we like to give it IV over 40 minutes for 0.5 milligram per kg. But we don't really like to use IV stuff in palliative setting. Or we can give it subcut bolus, or we can give it as a driver. There's not yet a head-to-head comparison in the palliative setting for these kind of different routes. There's some investigation for intranasal ketamine, and we've also done sublingual ketamine for pain, but we have to translate it over for depression. Nonetheless, we know potentially there's a role for ketamine in a setting to in a palliative setting to rapidly reduce depressive symptoms and suicidality within hours to days, to bridge typical antidepressant, as well as to potentially help with coexisting central sensitization pain. So we need more definitive study there. So therefore, to finish off, I want to say palliative, if we do well with mental health service collaboration, and do routine screening, prompt assessment, and proactive intervention, we actually can evade or stop depression from happening, and is therefore not an inevitable fate for people to die depressed. So to finish off, the screening approach means we need to conduct routine screening followed by prompt assessment and intervention using feasible and low burden manner. We do need a cultural change to create a supportive culture for depression recognition, assessment, and management. We need more research and openness to research in this area using innovative study design that is unconventional. We need to create a good supportive physical environment for people to be able to disclose their issues to you and prioritize resource. When you have another nurse who are spending time with a patient who's depressed, say, hey, actually, I'll cover you to sort out another patient who's in pain, rather than say, hey, what are you doing talking so long to this patient? Come out and then let's go and deal with the physical symptom patients. We need to encourage patient and the carer to disclose depression symptoms to destigmatize mental illness, engage with training in these areas, and promptly intervene, especially if people are about to die, in empathetic approach to care with a multidisciplinary team, and individualize their goals. And lastly, we need to advocate for integration of psychiatry and palliative as a routine part of care, so that we don't have to say, hey, to the patient, I'll get you a psychiatrist, and they're saying, I'm not mentally unwell. Whereas we can say, oh, as part of our palliative team, we are all coming together to see you. And we, as two, there's also a psychiatrist or psychologist just by the bedside together. So I'm gonna go into a fun quiz time. Hopefully
Now,
everybody falling
now,
asleep.
Wei, that's been very wonderful. So, like, if you could hear them there, they'll be giving you a round of applause, but you can't hear everyone. But I think before we go to anything further, I think you've probably got a chapter in a book or a book ready to go, right? Like, thank you for leaning into this space. You know, we're so grateful and so lucky as an industry to have someone who's put this much thought and wisdom into what you've just taught us. So thank you, Wei. That is quite incredible. And I think we've run a little bit over, and I wonder whether, yeah, I think what we might do is we'll put your slides, we'll email the slides across to everyone, which will include the quiz. Oh, there they are right now. So if you want to quiz yourself, you can look at the PDF attached. But there is one question in the chat. I think that's probably the most valuable spot to go. And Neve has popped there. Is there any different dosing considerations if a patient for ketamine if a patient is already on regular opioids?
So the answer is the dosing consideration is not for ketamine, but the dosing consideration is for opioids. So we do use ketamine for what we call wind-up pain. So if you have a patient with where you give, let's say, morphine, or it most commonly happen in fentanyl actually. So you give them morphine, and then over time they quickly says, "Oh, my pain is not working. Things are just getting much, much, much more painful. Their mood become irritable. They become depressed, and then become drowsy because the patient is having opioid-induced hyperalgesia." Then one of the treatment is you actually then start ketamine. So ketamine is useless for for the usual pain. It is also not very useful for neuropathic pain. However, it is very useful for central sensitization pain, or what we now call nociplastic pain. If you then give somebody on opioids ketamine at a good going pain dose, what it does is it resensitizes the whole body to the opioids again. And then this patient then can suddenly become drowsy because they now can get opioid toxic. So if you then, after starting ketamine and the patient gets drowsy, the treatment is actually not to stop the ketamine, but to quickly downgrade the opioid, for example, by at least by 50 to 75%. And that's what, by the way, a lot of pain team uses it for, to try and downgrade the opioid requirement. And
Cool.
so if you ever have patients on high dose opioids and then you give them ketamine and this happens, they're drowsy, quickly downgrade the opioid dose.
Okay, thank you, Wei. Look, Wei, that was really so informative. And if you can see the chat, I don't know if you can, but there is a ream of people saying thank you, thank you. That was so impressive. We're very, very lucky. So, and I agree with everyone. So if they can quiz themselves, you can quiz yourself in your own time. But Wei, thank you very much. And that is the conclusion of our Wednesday afternoon webinar. So thank you very much, Wei, and everyone
Thank
else. Have a
you.
lovely afternoon. See
Bye.
you again